Good morning. My name is Cody Powers. The date is June 3rd, 2020, and I'm here to read my Unit 4 Case Connection paper. I chose to look at Case 1. So in Case 1, we are presented with a newborn girl experiencing lethargy, hypothermia, and apnea at 24 hours of life. The doctor believes that the symptoms are related to a disorder of beta oxidation or a disorder of the urea cycle. This diagnosis may be difficult as these disorders of metabolism may present with general and similar symptoms. We are given 4 diagnostic tests and tasked with determining which test will help us best distinguish between the metabolic disorders. The diagnostic test that will help us determine the disorder should be able to give us sufficient evidence about both pathways, the urea cycle and beta oxidation. This paper will explore disorders of metabolism as well as the diagnostics tests provided. I believe that the plasma glutamine test is the best diagnostic tool as it is the most conclusive in distinguishing our metabolic disorder. A blood glucose test is insufficient in determining our disorder. The urea cycle does not play an important role in maintaining blood glucose levels in the fed or fasted state. A blood glucose test does not give us much information about potential disorders of the urea cycle. In comparison, fatty acid oxidation does play a role in maintaining blood glucose and is of utmost importance during the fasted state. Carnitine palmitoyl transferase transports serum-free fatty acids as acetyl-CoA into the mitochondria, where they are oxidized into acetyl-CoA by fatty acid oxidases. Gluconeogenesis, specifically the enzyme pyruvate carboxylase, is allosterically activated by the end product of fatty acid beta oxidation, which is acetyl-CoA. Gluconeogenesis as a process will be slowed down if beta oxidation fails to produce enough acetyl-CoA. That being said, a blood glucose test is not the best test to distinguish between disorders because it only gives us information about beta oxidation and not the urea cycle. A serum fatty acid test only gives us information about beta oxidation and therefore is not the best test. Of note, beta oxidation is under hormonal control while the urea cycle is not. In the fasted state, beta oxidation forms acetyl-CoA, a product of the interaction between acetyl-CoA and fatty acids. We will see an elevation of free fatty acids if a deficiency arises in the enzymes necessary for beta oxidation. We will also see free fatty acids rise if there is overproduction of fatty acids secondary to increased lipolysis activity. However, a serum free fatty acid test would tell us nothing about a disorder in the urea cycle. Free fatty acids in plasma are not used in the urea cycle, and nitrogen is not synthesized and does not need to be disposed of. We can glean information about beta oxidation and urea cycle disorders from urinary acid levels. However, it does not appear to be the most specific diagnostic tests given the prompt. We're not given enough information about the urinary acids in the patient's urine, and both beta oxidation disorders and urea cycle disorders can lead to elevated urinary acid levels. Elevated levels of acetylcarnitine can be found in the urine if there is reduced carnitine palmitoyl transferase 2 activity secondary to a deficiency in carnitine, which results in a reduction in beta oxidation. An often diagnosed disorder of fatty acid metabolism is medium-chain acetyl-CoA dehydrogenase deficiency, in which there is an increased level of decarboxylic urine acid in the urine. Urea cycle disorders can also become apparent using urinary acid tests. If the enzyme ornithine transcarbamylase is deficient, carbamoyl phosphate builds up in hepatic tissue, eventually increasing the activity of the pyrimidine synthesis pathway. Shunting to this pathway results in the overproduction of orotic acid, which is excreted in the urine and termed orotic aciduria. The patient did have markedly elevated urine orotic acid levels. Of note. I believe that plasma glutamine levels would be the best diagnostic test to distinguish between a disorder of the urea cycle and a disorder of beta oxidation. Elevated glutamine levels are very characteristic of urea cycle disorders. In contrast, decreased levels of glutamine are often observed in fatty acid beta oxidation disorders. Explained, if the urea cycle fails to remove excess nitrogen in the body, hyperammonemia occurs. Ammonia is toxic to the body and at certain levels fatal. Because of this, the body attempts to lower plasma ammonia levels by affixing ammonia to glutamine using the enzyme glutamine synthetase. The free ammonia becomes fixed as glutamine, which results in an increased circulating plasma glutamine level and lowers the ammonia level. In comparison, beta oxidation disorders can lead to fasting hypoglycemia, which can stimulate an increase in activity of gluconeogenesis. Glutamate is a glucogenic amino acid, as it can be deaminated into glutamine, which is a substrate for gluconeogenesis. We would see a decrease in plasma glutamate from increased consumption secondary to the increased activity of gluconeogenesis to make up for the lack of blood glucose contribution from beta oxidation. After reviewing the diagnostic tests and patient data, it is evident we are tasked with treating a urea cycle disorder. Increased ammonia levels and an elevation of orotic acid are both common abnormalities found on presentation of patients suffering from urea cycle disorders. One urea cycle enzyme that is least likely to be impaired is carbamoyl phosphate synthetase 1. There has to be normal and even increased production of carbamoyl phosphate because there is a marked elevation of orotic acid. And if there is an overproduction of carbamoyl phosphate, it is shunted to the pyrimidine synthesis pathway, causing an increase in formation of orotic acid. The most likely deficient enzyme in the urea cycle is ornithine transcarbamylase. A deficiency in this enzyme will result in an inability to synthesize citrulline from carbamoyl phosphate and ornithine. This will lead to a shunt and increased activity of the pyrimidine synthesis pathway and resultant orotic acid buildup. The citrulline level was slightly decreased in the patient's blood work. And then I chose to check out case 2. In case 2, a 4-day-old female presents with an elevated phenylalanine level. The physician suspects phenylketonuria, as the phenylalanine level was elevated. Phenylalanine is an essential amino acid, meaning it must come from exogenous sources found in the diet. Phenylalanine is metabolized into the end products phenylactate and phenylacetate, or into tyrosine. Tyrosine is a non-essential amino acid, but because it becomes essential if the body is unable to synthesize tyrosine from phenylalanine. Phenylalanine is normally converted to tyrosine, catalyzed by the enzyme phenylalanine hydroxylase. The cofactor BH4 must be present in order for this reaction to occur. A deficiency in BH4 or an impairment in phenylalanine hydroxylase will result in tyrosine becoming an essential acid. Again, the causes of the presentation of PKU include lack of BH4 and impairment in phenylalanine hydroxylase. When phenylalanine is unable to be converted to tyrosine, an excess of phenylactate and phenylacetate occurs and is termed PKU. Dietary restrictions were successful in this patient and led to a reduction in total phenylalanine levels. After discussing the metabolism of phenylalanine and the necessity of having BH4 readily available for the reaction, we can focus on the results of the BH4 loading test. Our patient, patient A, and patient B were given loading doses of BH4, and then blood levels were drawn and phenylalanine levels were determined. In patient A, we see that phenylalanine levels continued to climb at both 4 and 8 hours post-ingestion. We can determine that patient A must have an impairment in the enzyme phenylalanine hydroxylase, leading to PKU. The loading dose of BH4 helps us determine that the cause of elevated phenylalanine is not the lack of BH4, and continued elevation must be at the specific enzyme level, not cofactor level. Patient B was able to metabolize phenylalanine into tyrosine, as evidenced by the decrease in phenylalanine levels after BH4 supplementation. Because BH4 supplementation improved the condition, it indicates that the dysfunction lies in the biopterin process, most likely the synthesis of BH2, not the regeneration into BH4. This is presumed because phenylalanine levels continued to decline 8 hours after ingestion of a loading dose of BH4. Thanks for listening, guys.